just in addition to being an academic, I am a geriatric nurse practitioner and have been in practice for over 32 years now, with the focus of my practice being on long-term care, caring for older adults in adult daycares, nursing homes, assisted livings. And so I'm very familiar with this problem that we're talking about today. And when I teach my nurse practitioner students, one of the things that I emphasize in talking about kind of the care environment is really being mindful about how they're prescribing psychotropic meds. And Kelly, you were right. Psychotropics is kind of the broad term for medications that we prescribe for, behavioral mood issues. Antipsychotics being kind of a subclass of that. But it's important, whether you're a clinician or a lay person, to understand that clinicians need to take prescribing very seriously, and that when we prescribe medications, it's based on assessment, and it's based on the result of an assessment, some type of finding that really warrants the use of medication. I think, this slide really, these are statistics that are from 2017, actually. When you look at the percentage of people who have dementia in various care settings, these statistics really haven't changed significantly over the years. But when I began practice in the 80s, it wouldn't be unusual to see more than 50% of a resident population within a nursing home medicated somehow with some type of psychotropic, and particularly antipsychotics. And just to give you some context, back in the 80s, even when OBRA came into play in 1987, nursing homes weren't really tightly regulated, and clinicians were never questioned about prescribing practices. So if you had a resident that had a mood issue, somebody who was talking too much, somebody who was wandering, restless, anxious, calling out, resisting care, and I'll talk more about this in a minute, oftentimes the result of the assessment of that behavior was that these are symptoms that needed to be medicated. Call is made to a clinician, and the most popular drug probably in the late 80s, early 90s was Haldol, and no one would have questioned whether or not we put someone on an antipsychotic to try to extinguish those behaviors that I just outlined. And this is really the crux of what we're talking about today, because we no longer are allowed to do that, thank goodness, and that nursing homes are more tightly scrutinized and regulated to make sure that there is hopefully an assessment process in place to figure out, what is the mood, what is the symptom that the resident is exhibiting, and is medication really necessary? Now, I should say that while we have made some progress, as Kelly pointed out, there's still a problem in that the last person to be questioned about the prescribing of a medication is a clinician. We are the least challenged in terms of clinical decision making, and yet we should be held accountable for when we're asked to prescribe a medication to make sure that there is an indication for it, and more importantly, that there's a process for follow-up and reassessment of the need for that medication. So anyway, this first slide really is just to show you that, dementia and problems with cognition are pretty prevalent in the long-term care setting with about 50% of nursing home residents. Next slide, please. And what I want to outline too is that what we're talking about today is we're medicating people for what we call behaviors or psychological symptoms that are associated with dementia. So, psychosis is one of them, but there are also other symptoms that people present with that are often medicated. What I want the audience to understand is that when we're talking about that, we're talking about, that people with dementia, because they have frontal lobe damage and, in various stages, have disturbed perceptions. to disturb perceptions of their environment, what it looks like, what people are saying to them, what a caregiver is trying to do. And so there's a disturbance in the thought process and thought content and sometimes mood and behavior. It is, often if you see someone with dementia where they don't have any mood issues, you're pretty lucky, because a large proportion of nursing home residents in particular do have some mood issues associated with it. And someone in the question and answer box there did point out, and I've seen this too, that we've seen a rise in some of these mood or behavior issues with the pandemic because of nursing home residents being socially isolated in their rooms because of the need for social distancing, and also with the decrease in activity related to that social isolation. So as I said, this statistic's pretty high, but 90% of patients with dementia, sometimes will have one type of mood disturbance. It does impact the caregiver burden, whether it's spouses or children caring for older adults in the home or in a care environment. And these behaviors that people exhibit, and even that Kelly pointed out, cause, distress, not only to the caregiver, but it actually causes distress to the individual themselves. And you can see why, because of that, and because of the high incidence that has led to an over-prescribing of medications in the absence of really a true clinical syndrome that needs to be medicated. We know that the use of psychotropic meds and the overuse or the overprescribing has led to admission to long-term care institutions because of that example that you pointed out, Kelly, at the end of your presentation, where it can create problems with the individual, where their cognition is impaired, they've lost function, they can't eat, they've become incontinent, all from the medications requiring long-term care admission. Next slide, please. So think about this, when you think about some of the behavioral and psychological symptoms of dementia, these are think about how does memory impairment lead to a behavioral issue? Well, here's an example. A resident or a patient is not able to dress himself because they can't remember, where his clothes are kept, right? Because the association with a closet or a dresser is lost. And so that person walks around naked, which to most of us who understand dementia is understandable because of the loss of brain function. But to other people, they might see that behavior, someone walking around naked, as a problem that they want to extinguish. And so it might lead to, the prescription of an antipsychotic with the hope of trying to ameliorate that symptom, when in fact we know that it doesn't do that. Next slide. Again, impaired recognition. So that's a term, a technical term called agnosia, where a person doesn't recognize objects that are familiar to them when they don't have memory impairment. So an example is someone can't maneuver to use the bathroom. They can't maneuver to pull their pants down because they don't recognize that a toilet is a receptacle for urination, something that we automatically do in our everyday lives. But people with dementia don't look at a toilet all the time and think that that is what it's used for. And so they urinate on the floor. That's a problem behavior, and often seen in nursing homes where people urinate in various places. Again, that could trigger the use of a medication to try to extinguish that behavior, when in fact a medication isn't going to do anything related to that particular symptom. Next slide. And the last is the performance of motor tasks, which we call apraxia, when there's an impairment there. So a person is continent, but they can't unzip or unbutton to pull down their pants, and so they wet their clothing, they're incontinent, leads to staff frustration. Maybe they, instead of helping the resident with this, they automatically put a brief or a diaper on them, which leads to maybe a behavior issue because the resident doesn't want to wear a brief. Again, down the road could lead to the overuse of medication. Next slide. So these are some of the behaviors that I described, a few of them earlier, that I want you to think about. You hear often and many times when families are called about their loved one having a behavior, the behaviors that are described can encompass, physical and verbal, such as, they're restless, they're wandering and pacing, they're hitting, scratching, and biting, resisting care, they're throwing things, they're socially inappropriate, they're making sexual advances on other residents, they're screaming or cursing, or they're having a temper outburst. Or a psychological symptom that is different than the person's baseline, where they have now new symptoms of depression or anxiety. They're apathetic to their mood. They're just not as initiated or engaged. They have sleep disturbances, and then often, sometimes people with dementia, often in the later stages, show signs of psychosis, where they're hallucinating, they're seeing things that are not there, or they're delusional. These are all behaviors that, again, have led to the overprescribing of psychotropic meds that really require, most important point of today, is really require an assessment about what is actually going on. Next slide. And so the most important thing that I teach my students and when I'm mentoring in the clinical setting is that all behaviors have a root cause. So all behaviors have meaning. Many of you have probably heard that before. I would encourage, family members to ask when they're getting that phone call about, my mom is restless, your mom is restless, or they're wandering and pacing, is to ask the question of why. What's different? Is there something going on? And so it is so important to really ask for the staff in any facility and the clinicians to try to identify what's going on. What's the underlying cause of the agitation or aggression? And I really, to be honest with you, I don't like the word agitated or agitation. My colleague that I worked with Kelly many years ago, we used to always say that the person's upset. Something is, instead of saying agitated, which I think is pretty pejorative, it's really a derogatory term. It's more that they're upset. Something is triggering a behavior that we really need to look for the root cause. So some of the reasons that people have changes in behavior, they're experiencing a delirium. It might be a medication side effect. It could be that they have a sensory deficit. They can't hear. Their vision is impaired, something like that. They might not be able to express themselves because they have advanced cognition deficit, a cognitive deficit, or language deficit. They can't put the words to what they want to say, what they want to ask for. They have unresolved pain. They're not sleeping well, and many of us can attest to the fact that if you don't have a good night's sleep, what that actually does to your overall sense of well-being and your mood. Some people are experiencing depression or anxiety or apathy and psychosis. They have an unmet need. They're hungry. They're tired. They need to go to the bathroom. They need to get up and move. So they have an unmet need, and there might be an environmental trigger, like they don't like the person at their table. It's cold in the environment, too much noise, the lights are on, staff are screaming at them. There could be so many issues, but key here is really to identify what is going on that is creating this response, this mood change. Next slide. And so the first thing really, in addition to really looking for the root cause, is if there is going to be some type of intervention, and there really should be, it's really looking first towards non-pharmacological management. The studies have shown that not using meds has been shown to really reduce agitation and anxiety in people with dementia. and that those techniques that are used to help kind of reduce, take the person down, get their anxiety down, needs to be individualized. What's actually going on with that person that we really need to address. And non-pharmacological interventions really incorporate, three kind of buckets. One is behavioral interventions. The other is caregiver education and training. And here, I'm really talking about education and training of nursing home staff or assisted living staff, where they really understand this is how you address or deal with somebody when they're having a mood issue and they have advanced dementia. This is how you approach them. This is how you should talk to them. Sometimes just using touch or no touch at all. And then incorporating other sensory techniques. It can help actually reduce agitation or upsetness and anxiety without the use of medications. Next slide. So the other thing is to think about what is triggering the behavior in that individual and to avoid those triggers. So people respond better when they have a consistent routine and environment, when there's predictability to it, and when it's individualized. So if I am ever in a nursing home, I get up at 5 o'clock in the morning, and I hope that routine would be honored if I'm ever a resident in a long-term care setting, or someone who's worked night shift all their life. Like really that the environment is really tailored towards that individual's needs. And to avoid, sudden changes in routine that can really precipitate increased confusion and then subsequently the agitation. Somebody's used to a shower at a certain time of day, or if it's a trigger for someone to have, lukewarm water versus hot water, all those kinds of things that really would upset us as individuals, really making sure that we avoid those triggers in people with cognitive loss. Determine and anticipate unmet needs. So if someone has pain, to make sure that they're on a routine, that their pain is addressed and that they're on a routine regimen to address, chronic pain. Are they hungry or thirsty? And then also to really incorporate, appropriate language that can actually facilitate communication. Cognitive deficits can't respond to conversation like we're having today. It might be simple cues like, come with me. Are you hot? Are you hungry? Or just, nonverbal behavior cues for someone so that it helps facilitate communication. And the last bullet's really important. I'm sure all of you have heard about person-centered care. To me, what that means is really looking at the individual. There's not one plan that works for everyone who has some behavioral symptom related to dementia. It really is based on that individual. And it is important to incorporate what the family knows about that resident that can actually help them if they're exhibiting behavior. Some things that I have found very valuable information from spouses and children that said, hey, when dad was upset when he was younger, this is what we did. It's so important to incorporate what we know has worked in the past and what the family can bring to the table. Next slide. I talked about a little bit about, caregiver education, communication skills training is so important. Provide a calm, reassuring communication when that resident seems anxious, and use redirection and distraction techniques. If the person is taking them to the shower and it's not the right time to take a shower, the appropriate thing to do is to try it again later. Engage in an activity that's creating anxiety to begin with. Next slide. And then, incorporating other sensory techniques that we know actually do help in the long-term care environment, using aromatherapy, music therapy, massage, and touch if appropriate. Exercise, can't underestimate and overemphasize the impact of exercise and activity on reducing anxiety and agitation, and then pet therapy as well. These are all easy interventions that facilities should incorporate, obviously, before they consider a medication. Next slide. I like the term or the phrase correct the correctable. So when I spoke earlier about looking for root cause, correct the correctable. If there's an infection, Kelly mentioned a situation where somebody had a urinary tract infection, then correct that, treat it. If someone has pain, treat it. If someone needs to move, get them up and move them. If they're hungry, feed them. If they're diabetic and their blood sugar dropping too low is really what precipitates a behavior, make sure it doesn't drop too low. Monitor that person closely. Can't say enough about stopping non-essential medications. This is something families should ask about all the time, to look for drug interactions. Is there some drug toxicity, some other medication the person is taking, or some drug-to-drug interaction that is really causing this change in behavior? Always should look at medications and reduce them. Reduce psychiatric symptoms, and sometimes that is it is necessary to treat with other types of psychotropic meds to reduce the psychiatric symptoms, like treating depression. Provide structure and emotional support and maintain function. Keep people, get them out of the rooms, get them out of their beds. Next slide, please. So I do want to mention, and just to dovetail on what Kelly was talking about, sometimes medications are needed. And usually, antipsychotics are, in my opinion, really the last resort in terms of there's many medications that can be used to treat anxiety and even psychosis. And we don't have to resort to antipsychotics. We do know, as Kelly pointed out, there are black box warnings that providers and pharmacists should know about. There is increased use of these medications, especially with people with dementia, the risk of stroke or myocardial infarction and even death. Again, reserve these meds for symptoms that are really severe. Like, is it really causing the person extreme distress and really imposing or preventing them from functioning, or does it pose a safety risk? So is the behavior posing a risk to the person themselves or to those in their environment? Agitation and aggression that is not managed through any of those other interventions that I already spoke about, and psychosis that is debilitating. So someone believing that they see someone in their environment that's not there, or that they're talking to someone that's not there, or they call you mother when you're not their mother. That's not a problem. That's expected sometimes with people with cognitive loss. That is not a reason to medicate people. And, antipsychotics really should not be used routinely. And key point here is that if they are prescribed, that they should be regularly reassessed. There should be a time frame for when that medication should be used. One example is if a resident goes to the hospital and has an infection and they develop a delirium, which is a temporary, time-limited exacerbation or increase in a level of confusion. Sometimes when they're hospitalized, they will be treated with antipsychotics. When they come back to the nursing home staff are required to really reassess, is this medication really needed? Is this related to this hospitalization and this acute infection? It is their job to make sure that the medication isn't continued indefinitely. And that is something that I routinely do in my practice. And I think that all families should ask the physicians and nurse practitioners that are taking care of their loved ones to really reassess the need for an ongoing use of an antipsychotic. And really, there's no clear evidence indicating the benefit of the first generation antipsychotics in dementia. So the first generation antipsychotics, as opposed to the newer ones, are the ones that really caused or really have potential to cause some of those side effects that Kelly outlined earlier, especially tardive dyskinesia, those Parkinsonian symptoms that people get as a side effect from using these medications. Next slide. So I said, if you get a call that, they're going to order Zyprexa or Risperdal or Geodon or whatever, I would want to make sure that, there's a clear description of the need that the behavior, it poses a danger to that individual or others, that they have uncontrolled agitation despite all those non-pharmacological interventions, that there's anxiety or, unrelieved anxiety in the presence of agitation or hallucinations. And, there might be a temporary need to decrease the agitation for diagnostic, a test that the person needs to have, or some other type of clinical intervention. Again, even in these scenarios here, time limited, and really the need for reassessment, as to the ongoing need for the medication. Next slide. Kelly talked about the FDA warning, the black box warnings. We do know that antipsychotics as well as other medications increase the risk for somnolence. So I want to just outline here that when I mentioned earlier in my presentation that these meds were used widely in the early 80s, all they do for people with dementia, they don't cure any symptom. They don't change the brain chemistry. They merely sedate. And so it is expected that if you're going to give someone an antipsychotic or a benzodiazepine like Ativan or whatnot, you're going to cause sedation. It suppresses the central nervous system. So people who are on these medications have an increase of falls and fractures because they're somnolent, they're sleepy. They also have risk for postural hypotension, which means that they stand up, their blood pressure drops, and they have an increased risk for falls. And that they can have motor and sensory instability as a result of the use of these medications. So again, these individuals are at risk for falls and other related types of injuries when initiating antipsychotics, and then if they're used for long-term use. So it should, again, always be reevaluated. Next slide. And so just in summary, we do know that there's a wide range of behavioral or psychological symptoms that people might present with dementia. And as dementia progresses, sometimes the potential for these symptoms to occur is going to increase, and expect them. It is important to really identify what is going on. What do they think is causing this increase in agitation and aggression? The symptoms might be related to either an acute or chronic illness, and which really should be evaluated. Many of those symptoms that I described can be managed by use of non-pharmacological methods, and there's so many that should be tried first. And caregiver education. Antipsychotics reserved, when safety really is an issue. Always question if they're going to order one, what is the symptom that they're trying to ameliorate, and what's the plan for tapering the person off. It is a requirement in nursing homes to do what we call a GDR, gradual dose reduction, every 6 months. And that's usually triggered by the pharmacist, looking at the drug regimen to suggest that to a provider. I would hope that providers do that before someone tells them that they need to do it, because it should always be a clue when you're looking at a resident's med list that anyone on any antipsychotic should be reevaluated. And that they really should not be used routinely. There are so many other medications that can be used if a person has depression or anxiety that are much safer and really have a far less risk of, side effects, decreased function, and even death. Thank you.